So hello and welcome to the talk on communication. And not going to give a talk on how to communicate, but it's really more a talk on whether we should communicate and how we can improve the quality of communication. So I'll just go to the PowerPoint now and we can get started. So I'll just share screen. I'll do all these complicated things and here we go. So title of the talk is Should and Can We Improve the Quality of Communication During Consultations? And that's the topic. Should we? Why bother? And why is communication important? So to start with, I think there's some really compelling evidence about why communication is so important. And I'm giving you the data from a meta-analysis conducted by a team led by Hassan. And they looked at the odds ratio, in other words, the likelihood of good adherence to medication, depending on a whole bundle of factors, including the type of drugs, the complexity of the regime, and so forth. And they came up with what are called odds ratios. So an odds ratio of 1 means that there's an equal probability if people communicate of people taking the medication. If in the top one here, complexity of regime, if you have a complex regime or a simple regime. And in fact, overall, it didn't make much difference despite, I think, the emphasis we have on that. Health literacy. Now, patient characteristics, where people were very health literate, there was nearly 5 times more likely to take their medication and adhere properly and fully to the regime if people were health literate. But look at the bottom thing here, patient-prescriber relationship. Such a, unexpected factor, and yet if there was a good relationship between patient and prescriber, patients were 10 times more likely to adhere to the medical regime recommended than if they had a poor relationship. And that is primarily a function of the quality of communication consultation. So, perhaps surprisingly, the impact of the relationship between patient and prescriber on such a key outcome as medication adherence is profound. Other things that came up as predicting adherence or lack of adherence were misunderstandings, poor communication, and so forth. So there was a range of factors that were coming through, but the most important one was actually the relationship between prescriber and doctor. So maybe we don't need to improve adherence, but adherence is really good. So I'll raise a couple of other studies now. Again, looking at adherence to DOACs. And again, the first study here is a meta-analysis by Osaka et al. And they did a meta-analysis, and admittedly, it wasn't in people that had thrombosis. It was people with atrial fibrillation. So, maybe there are expectations given these people hadn't had clear health problems as a consequence of their atrial fibrillation on the whole. Maybe they don't compare that nicely with people that have had a thrombosis because they've had a clear health crisis. But if you look at the results from the 48 studies here, adherence was modest. It varied across drugs, but what they reported was that good adherence was found between 60 and 70%. So roughly a third of patients were not adhering well to the medical regime. And there was a single study here by a pharmacist, and they did a time series analysis looking at a whole series of patients as they came through to see a pharmacist. And what they found was that adherence issues were in 61%, 2/3 of people on rivaroxaban and 33% of people on apixaban. Now, there's many reasons for that. But nevertheless, the critical thing is that adherence was perhaps less than optimal. So, we have a link here between patient-prescriber relationship communication and adherence could definitely be improved. It's also good for health professionals, literally good for health professionals. There's a review by the people on the left here, Abdel Rahman and Abdel Ramigid, and they looked at complaints made to the GMC. And the top 3 complaints during the previous year were concerns with investigations and treatment. That makes sense. But the next 2 were about quality of communication and relationship, problems with communication, and perceived lack of respect for the patient. So, patients see it as important. If you want to be a good health professional and avoid going to the GMC or the equivalent of whatever profession people are in, it's pretty important. And as I said before, if you want good quality care for your patients, then we know that communication is crucial for poor adherence. If people don't have a good quality of relationship, they're more likely to exaggerate their symptoms. So there could be complexities and confusion over the nature of problems, and diagnostic errors are more likely. So there's a whole bundle of reasons why all of us need to communicate and communicate effectively. I think part of the problem is that if you look at the fundamental differences between maybe the goals of patients and the goals of health professionals. So if you look at the left here, we have, the goals of the health professional are essentially to obtain information, convey information, what drugs to take, when to take them, you've had a clot, what to do, and then to agree and get the patient leaving with the knowledge of what they've got to do and willing to do it. And on the right, we have what the patient may want. And you don't need to read these all, but the whole point is that there's a whole bundle of questions, a whole series of issues that the patient may want to address and not be aware of. And I know I'm being slightly stereotypical here, but at its fundamental level, these are the critical issues. There's a difference between the goals of health professionals, which are to help the patient get the information that is necessary over, get them on the right medication or ensure they're taking it. And then, the patient will have a whole bundle of questions. And if those 2 goals are not met, then the health professional doesn't feel happy because they haven't got their information over. But equally, the patient doesn't feel happy because they feel that issues that are important to them haven't been addressed. So the key is, how do we address those? I think one of the worrying issues about how do we address this and what should we be doing about it is that a lot of health practitioners are going to say, "Well, I do a good job. I think I do a good job, so you can tell me later if I do a good job in this talk or not." But one of the frequent findings is that practitioners, on the whole, are not aware of their communication skills. And these are just 2 studies of many that show there is a dislocation between when practitioners think they've communicated well and when patients think they've communicated well. So the Zachariah et al. Study, they looked at a whole range of things. And repeating what I've said before really, but key to the patient's perspective was they felt the physicians had understood their feelings. They understood their viewpoint. There was a quality to the contact. People were engaged, taking an interest. And that meant that they were confident in the practitioner quality in terms of medical decisions. But critically, what they also found, because they measured ratings of communication skills, is that the doctors who evidenced poor communication skills were least aware of the patient's responses and level of dissatisfaction. In other words, they thought they'd done a good job and patients were walking out, satisfied. It wasn't the case. And again, another meta-analysis by Rotella et al., meta-analysis of physician and patient assessments. And in 17 studies, they found 10 of those, the majority found no association between physician and patient ratings of quality. And 7 studies found poor to fair agreement. And I think this partly reflects maybe people are not aware of how good or bad a communicator they are, but also those different agendas. And it may well be that, you know, the doctors felt they'd got their medical viewpoint over well, they constructed it and so forth. Whereas the patients were thinking, hang on, what about my agenda? What about the issues that I'm interested in? And to non-medics watching this, I apologize because there is a predominance of doctor-patient communication, but sadly that is probably reflects the data out there, but I'm sure it's the same for other professions as well. So how can we, if we accept that there is a problem, that there is this gap between patient and health professional perspective, communication is not always found to be good by patients. And there is an acceptance that perhaps I need to at least think about my communication because I thought I was good, but perhaps I'm not as good as I thought I was. And you can write your comments on this later if you like, so you can put me in my place. But how do we improve communication? Well, there's a number of ways we can do this. You know, if you go to the NICE guidelines, there's some clear guidelines about what we should be doing in consultations to improve. And as the title of the thing says here, NICE guidelines from compliance to concordance. So this is about not about patient satisfaction, but this is guidelines for maximizing adherence to medication, however you describe that. And I'm not going to go through them all, but just to give you some ideas about the types of things that they say. So they suggest that offer all patients to be involved in making decisions about prescribed medicines. Establish what level of involvement in decision-making the patient would like. You know, some people just like to be told, my advice as a doctor is do X, or as a pharmacist or as a nurse prescriber, do this. But many patients would like to be involved, you know, what are the pros and cons of this medication, etc. Avoid assumptions about patient preferences about treatment. Talk to the patient to find out their preferences and note any non-verbal cues that may indicate you need to explore the patient's perspective further. And, you know, recently we did an online sort of seminar talk about men's issues and anticoagulants, and, you know, things like exercise, things like sport, things like, you know, adventurous things that people may want to do. They may be part of that process of making decisions about whether to continue people on, you know, medication after the 3 to 6 month decision-making point, if people are on anticoagulants and so forth. So, you know, it's about taking on board and exploring some of those patient perspectives. You know, and, you know, I think the one at the bottom is really quite important. Accept that patients may have different views from healthcare professionals about the balance of risks, benefits, and side effects of medication. You know, understandably, you know, the goal of the prescriber is to maximize the health of that person. You know, that may be slightly at odds in terms of the goals of the patients. And if they make an informed choice, then there may be a different outcome, a different regime, etc. But, you know, I'm not going to say these are good or bad, but there are guidelines about what we should be doing. Talk to patients. One of the things that I did in thinking about all of this was I asked patients what they saw as good elements of communication. You know, what did they, if they, you know, what did they walk out from a meeting with a health professional and they felt that it had gone well, they'd been informed, etc. And again, these are not definitive, but just to give you some ideas of what people were saying. You know, treat the patient, not the diagnosis or the symptoms. The patient is a person, an individual, and will have their own way of presenting their own problems related to whatever condition they had. You know, slightly long-winded, says he, knowing who wrote this. But the whole point is, that people treat with respect, say hello, talk to people, find out their perspective. At the same time, don't use long medical words. And this whole issue of, the use of medical nomenclature, and dare I call it jargon. I go and see a doctor and the doctor talks quite complex stuff, and I feel, the doctor thinks I know what I'm talking about. They think I'm an educated, well, knowledgeable person. They might not be. It might be they use those words with everybody, and not everybody is going to understand them. So, talk to a patient on their level, which will differ. Don't fanny about. Sorry, Paul, call a clot, etc. Use of language, etc. The most important of all is listen and read the patient and empower them to manage their condition and not be controlled on that. And that's a challenge. People say, I haven't got a long time in a consultation. I've got a whole set of information to give over. I haven't got too much time to listen to what the patient is bringing, what we need to talk about it. But there are ways of managing that. I'm not going to talk about those now, but there are ways of managing the consultation to allow both of those things, even in a fairly constrained. Give a sense of ownership to the patient. Simply saying to the patient, I'm your doctor, I'll manage your treatment and care, can make the world of difference. So giving people confidence, letting people know that you see them as a person and you're engaged with them. So there's many ways that patients say things can be improved. You can read a book, Effective Communication Skills for Doctors. There are things out there, and there are things for all the other health professions as well. I've made it rather small, so if I decide to write my own book, you won't necessarily go to this one, but you might think, I'll have a look at his. But yeah, you can read a book. And you can take a course, and there are many available. There's many online, and they do make a difference. There's quite good evidence that even online courses can be of benefit. But the real ones that really make the difference, I hate to say it, are the ones where you get to discuss, where you get to practice, where you get to think about what you're doing. And because of that, and the emphasis on communication that Thrombosis UK is putting on, we are actually developing both an online introduction to communication skills, but also some training courses that we can do between a half and 2 days at cost price. So they'd be dirt cheap, but they are ideally done live, where there's interaction, engagement, and they're fun and people think about them and so forth. So if after watching this you think, well, maybe we're thinking about doing something, then contact Joe or myself, and we may think about sorting something out on that. So yeah, there we go. We need to do it. We're not always aware, we're not good at it. There are multiple sources of how to improve, but take a course is frankly probably the best way. But even if you don't do ours, do it live, do it engaged, do it with role play and all those things that we all groan about, because frankly, they are the best way to do these things. So if you have, thank you for listening, and thank you and goodbye. Take care.